Hello, welcome to today's What's New in Research webinar. I'm Jenna Invalo and I work with the MGFA. Before we get started, I want to take a minute to thank today's webinar host, Cartesian Therapeutics. I also want to go over a couple of housekeeping items. Today's session will be recorded and available to view on YouTube following the presentation. If you would like to view the recording or the webinar with closed captions, please click on the CC box located at the bottom of the Zoom icon and select English as your language. If you have questions during the presentation, please submit them in the Q&A icon located at the bottom of the Zoom menu. And now it's my pleasure to welcome today's speaker, Dr. Milos Miklovic from Cartesian Therapeutics. Welcome.
Thank you. Let me share the slides here. Thank you everyone for joining, and I'd like to thank MGFA for hosting this webinar. My name is Milos Miklovic. I'm the Chief Medical Officer at Cartesian Therapeutics. I'm a hematologist oncologist by training, but for the last several years I have been more involved in autoimmune disease and in neurology in particular, in Myasthenia Gravis. Cartesian Therapeutics is we like to call RNA cell therapy company, and I hope that by the end of this talk, you'll know what that means, what RNA CAR T cell therapy is, and how we think it can help people who live with Myasthenia Gravis. So we will talk about what CAR T cells are. We'll review the process of manufacturing mRNA CAR T cells and how they actually work in the body, or how we think they work in the body. I will discuss results of our recently completed phase 2b trial, a randomized placebo-controlled trial of our lead product, Descartes-8, in Myasthenia Gravis, with full 12 months of follow-up of these patients. And I'll conclude by showing you the design of our phase 3 study, which is currently ongoing and enrolling patients. Before all of that, disclaimer, the Descartes-8 is an investigational drug and is not approved by the US FDA for any purpose. So let's talk about mRNA CAR Ts. And I'd like to start with this slide, which is a very successful attempt by a cartoonist to depict all the different components of the immune system. And you can find many different cartoons, and most of them are way off base in what they show. This is a very good one, and point number one is that this is a very complex system with many interacting cells which do many different things. For this talk, we only need to talk about these two actors. One is the cytotoxic T cell, or a killer T cell, and that's actually the cell that we turn into a therapeutic cell by adding something called a chimeric antigen receptor, or a CAR, to it. And the other key actor is the plasma cell. Now, both of them in a healthy immune system, in a healthy body, have the same role, and that is to attack foreign cells in the adaptive or learned immune response. There are many cells who can't learn, don't know, can differentiate between the good and the bad. These can, and that's why we call them the adaptive immune response. However, plasma cells sometimes go in a different direction, and they start producing antibodies that are targeted against our own cells and tissues, and that's a key occurrence in the pathogenesis and development of many autoimmune diseases. And myasthenia gravis is one of the main ones, when we know that there are antibodies directed against something called the neuromuscular junction that cause all the weakness and everything that happens downstream. Now, CAR T cells are a way to teach T cells further how to attack what doesn't belong in the human body. Now, they have been developed for malignancies. So all of the currently approved CAR T cell therapies are in use in different B-cell leukemias, lymphomas, a malignancy called multiple myeloma. And they all use viral vectors to teach the T cell how to attack, to introduce the CAR. We use mRNA, and I'll show you soon how mRNA is different from viral vectors and how it teaches the cell and what the effects are. Now, with CAR T cell, it's an immunotherapy. It harnesses the natural ability of T cells to recognize and attack a specific cell. So it uses the patient's own immune system, immune cells that are obtained through a process called leukapheresis. The CAR receptors, they're right here. That's how we teach the cell what to attack. And it's a multi-step process from the apheresis through manufacturing and to the final infusion. And that each Descartes 8 or each CAR T cell product really is patient specific. So every lot of product is unique to that one patient. Descartes 8 is an autologous mRNA CAR T cell therapy. So we discussed what CAR T cells are. Now, mRNA allows it not to require any lymphodepletion chemotherapy, so there's no chemotherapy involved. It allows it to be administered in an outpatient setting without inpatient monitoring and without significant toxicities that have been seen in other forms of CAR T cell therapy. If you hear about CAR T cell, or if you Google CAR T cell therapy, you'll usually learn about those viral vector-based CAR T cell therapies that do require lymphodepletion, that are administered in an inpatient setting, and that do have significant toxicities. mRNA is what makes it different. I already mentioned the production process. So it starts with apheresis or leukapheresis. Depending on the machine that it's used, it takes 3 to 4 hours to separate just the white blood cells from the body. Not all of them, but amount sufficient to manufacture the product. Those cells are shipped to our facilities that are in Frederick, Maryland. Then we grow the cells from a few 100 million to 1 billion cells. We grow them into tens of billions of cells. We insert the mRNA, and then we aliquot, we divide the cells, freeze them, and ship them to the clinic. The cells are shipped frozen so that they're stable for a very long time. And we know that usually it takes about 3 to 4 weeks from apheresis to the infusion, but it can be longer than that because life happens and people have plans and things can be delayed. Now, how does Descartes 8 work, or how we think it works, is by attacking the plasma cells. In Myasthenia gravis, plasma cells are the ones that create the autoantibody that attacks the neuromuscular junction. However, the plasma cell doesn't just pop out of nowhere. There's an activated B cell that's behind the plasma cell, and it turns into the plasma cell that secretes the antibody. And for that to happen, you need a T helper cell to help it, to teach it how to develop and turn into a plasma cell. The medications that are currently in use in Myasthenia gravis either eliminate everything above, so they act as a broad immunosuppressive therapy, so they hit every possible plasma cell and B cell and T cell, so you can be at a risk of infection, or they work the level lower. This is what's called the complement. The complement is how the antibodies actually do the destruction. So you can eliminate a complement, or you can remove the antibody, which some other treatments do, but they don't deal with everything above. So the plasma cells are still there, even if you are removing the antibody. So as soon as you stop that treatment, the plasma cells will continue producing the antibody. Similar with complement inhibition, you can inhibit the complement, but as soon as you stop it, the antibody is still there and the plasma cell is still there. Descartes 8 attacks a protein that's in the surface of all plasma cells and many of these activated B cells, especially the ones that are on their way to become plasma cells. So we think that doing that, we can hit Myasthenia gravis at a level of, above what other therapies are doing, but without causing broad immunosuppression. So that's the theory behind it, and it's a nice story, but the only way for us to know whether that's actually happening is to do clinical trials. And we have completed phase 1 and phase 2 trial, and we're now in an ongoing phase 3 trial in Myasthenia gravis. So I'll discuss the results of the phase 1 and 2 trial first. Descartes 8 initially was tested because we didn't know what the potential side effects would be in patients. So the first 3 patients were hospitalized and were closely monitored. We tested 3 different dose levels, low, medium, and high. We saw that there were no concerning symptoms during or after infusions. So every patient after that was treated in an outpatient setting. In part 2 of this study, we took the highest dosing level and tested 3 different dosing schedules. So either twice a week for 3 weeks, or once a week for 6 weeks, or once a month for 6 months. So same 6 infusions, but spaced out over different periods of time. And we saw that the once weekly schedule was optimal. It led to the deepest responses and to the most durable responses. And we have published that data in a journal called The Lancet Neurology more than 2 years ago now. And that led directly to part 3 of the study, which is actually a phase 2b placebo-controlled trial where we tested these 6 doses once a week of Descartes 8 against placebo. And it's what we call the blinded study, quote unquote. So neither the patient nor the treating neurologist knew what was being administered. And participants who were randomized to receive placebo had the chance of getting Descartes 8 after the trial. Here you can see the patients who were eligible for part 3. So early on in part 1 and 2, we tested in every autoantibody type, so both acetylcholine receptor antibody myasthenia gravis, which is the most common, MuSK myasthenia, and triple seronegative myasthenia. In part 2, we saw that people who had MuSK myasthenia did not have responses as deep or as quick as those with other antibody types. So we continued evaluating MuSK myasthenia in an open label setting, but they weren't eligible for the placebo trial. So in the part 3 in phase 2b, we had patients with acetylcholine receptor antibody myasthenia. We had a patient with LRP4 myasthenia and some patients with triple seronegative myasthenia gravis, but no patients with MuSK. We required an MG-ADL score of 6 and above, and patients who had class 2 to 4 myasthenia gravis were eligible. We did allow and do allow in the phase 3 study for background medications to continue, provided that the doses were stable for 8 weeks or longer. But we did require biologics, FcRn inhibitors, and CD19, CD20 antibodies to be stopped. And the washout, quote unquote, period was 4 weeks before the infusion. We did allow complement inhibitors to continue throughout treatment, provided the dose was stable for 8 weeks prior. And we also allowed steroids up to 40 milligrams per day, and methotrexate, mycophenolate, or azathioprine, in addition to the complement inhibitors. So what is MG-ADL? Just a reminder, I'm sure many of you know, but some may not. It's what we call a patient-reported outcome. So there are different ways if you can see that you can measure symptoms of myasthenia gravis. Some of them include instruments to measure the strength of the hand grip or the strength of the breathing muscles. But MG-ADL really relies on patients who live with MG telling how it's been affecting their lives for the preceding period, for the preceding week. And it's scored depending on the answer, these different domains. Score of 0 means everything was normal. There were either no symptoms of myasthenia gravis or the symptoms did not affect their lives at all. And the higher the score is, the more significant the symptom burden is. And the goal of any myasthenia gravis therapy is to get that score as close to 0 as possible. If somebody has an MG-ADL score of 0 or 1, meaning absolutely no symptoms or minimal symptoms, it's what we call minimal symptom expression, and that's really the goal of any treatment. So these are the results in our study. The blue line is patients who received placebo, and the change in MG-ADL score on the left and MG composite score on the right, starting from day 1, that's before the infusion, during treatment, where the dashed line is, and past that all the way up to 12 months. Now you see, early on, both patients who were receiving placebo and who received Descartes reported some improvement in symptoms. And that can be, you're getting an infusion and everybody's hoping that it'll work. It can also be the effect of apheresis. So we know that plasma exchange is used in myasthenia gravis, and leukapheresis is similar. It even uses the same equipment as plasma exchange. But very early on, very soon, you can see that there is a separation, and that patients who receive Descartes 8 continue to report major improvement in symptoms all the way to a year of follow-up, whereas patients who receive placebo have their scores go back to baseline or almost baseline at 3 months. And what's important is that a third of the patients of everybody who was treated had minimum symptom expression. So ADL score of 0 to 1 by month 6, and everybody who achieved minimum symptom expression maintained that minimal symptom expression all the way to 12 months. Now, the question is there any particular type of myasthenia gravis that was more likely to respond? And what we saw, and these are small numbers, so we don't know yet, but what we saw is that those patients who didn't have prior complement inhibitors or FcRn inhibitors had a much better response and a deeper and more durable response than the others. So more than half of these patients achieved minimum symptom expression and maintained it to 12 months. And when you look at the improvement in scores by numbers, ADL reduction at month 4 was 6.6 points, and at month 12, it was 7.1 points. For comparison, what's considered clinically meaningful decrease in MG-ADL score is 2 points. So it was more than threefold more than what's considered clinically meaningful. And we think that speaks to the depth of response and durability of response, especially considering that this was a single course of treatment. So the last infusion is where the dashed blue line is, and the improvement in symptoms continued for much beyond that. So those are two important points. The third important point that we saw was the safety. So what were the side effects? And early on in earlier studies, we saw that were not placebo-controlled. We saw headache, nausea, and fevers as the most common side effects. We saw headache and nausea occur in the placebo group at very similar severity and similar rates as they did in the Descartes 8 group. So it's hard to say that it's more compared to Descartes 8. The main side effect that we saw in the Descartes 8 group that wasn't seen in the placebo group were fevers. And they occurred 8 to 12 hours after infusion. They were associated with some chills, some muscle aches, body aches, joint aches. People described them as flu-like symptoms. Some of them had what we call rigors, shaking. Some patients compared them to the feeling you get after the mRNA vaccine, the COVID shot. Now, there's no similarity other than both using mRNA between a COVID vaccine and Descartes 8, but they describe symptoms like that. And similar to that, the effects went away the next day. So all of the fevers resolved within 24 hours. Some patients reported feeling a bit tired, fatigued 1 or 2 days after the infusion, but nobody had side effects that went beyond that, and nobody reported side effects after month 3 of the study, which means that the side effect we saw were really infusion related right around the infusion. And we planned for that. So there's some pre-medication given before the infusion. We planned for Tylenol, acetaminophen being administered around the clock for the first day, just for comfort. And we recommend some non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, or others to decrease the fevers. And none of the patients needed anything more than that. So nobody who participated in the study needed steroids to control these fevers. There are some other medications that are used for very severe side effects that did not need to be used. Another important fact is the infection rate. So I'll remind you that plasma cells do have their function. It's antibody production. So there's always a fear with this kind of treatment that you'll eliminate every plasma cell, that you'll completely decrease the antibody levels, and that you'll leave people susceptible to an infection. We did not see that. We saw exactly the same rate of upper respiratory infections between the two groups, Descartes 8 and placebo. We saw the same levels of immunoglobulins. Immunoglobulins are the antibodies that we measure in blood between the Descartes 8 and placebo groups. And when we saw the vaccine titers, so the protective antibodies against vaccines that are administered throughout life, like the meningococcal vaccine, like the pneumonia vaccine, tetanus, we did not see any change in those levels between Descartes 8 and placebo. And there are some scientific reasons why we think that is, why we think we target preferentially the autoantibody producing plasma cells, and that should come up in the medical literature, we hope soon. Another common question we get asked is retreatment. So how did those patients do longer term, even past 12 months? So this is data from 2 patients who were not in the randomized control trial. They were in the initial trial, part 2, the open label study. So both of them received 6 infusions each, and both of them achieved minimum symptom expression, at least for some duration. So the first patient had 1 visit when they had minimum symptom expression. The symptoms got a bit worse, but not sufficient not severe enough to warrant retreatment up until their 12-month visit, when they were back at the same symptom severity as they did before getting Descartes 8. They received 6 more infusions and again achieved minimum symptom expression that was even more durable second time around. So now they are more than a year out from retreatment, and they continue to have minimal symptom expression. The second participant received 6 infusions, had durable minimal symptom expression for more than a year. A year and a half later, they had recurrence of symptoms, received 6 more infusions, and again received minimal symptom expression. So in both patients, you have 2 years after initial treatment and a year after retreatment achieving minimal symptom expression. A third patient also had recurrence of symptoms after 12 months. They had a bit of a delay in treatment because they lived far away from the study site. So they've only just recently received retreatment, but again, they achieved the same or better response with retreatment compared to the initial treatment. And 4 of the 7 patients in this part of the trial, they're more than a year out from initial treatment and they haven't asked for retreatment. So those are the results of the study so far. I'll spend the last few minutes discussing our ongoing phase 3 study, which we call AURORA. So the design of AURORA is very similar to the phase 2 randomized controlled trial with a few key changes. One is that it's only patients with AChR antibodies are eligible. So patients with seronegative myasthenia gravis, MuSK, or LRP4 positive myasthenia are not eligible for this trial. Every patient who is eligible will undergo apheresis, and every patient's cells will be transported to Frederick, Maryland for manufacturing, where we manufacture both a lot of Descartes 8, a personalized lot of Descartes 8, and a lot of placebo. That's when randomization happens, and it's a coin flip, whether it's 1-to-1 randomization, which means equal odds of getting either Descartes 8 or placebo, masked. So again, neither the participant nor the study team knows what is being administered. There are 6 infusions once a week, and then masked follow-up at 2, 3, and 4 months. At 4 months is the main assessment, main measurement of MG-ADL, where we want to see what kind of responses in the Descartes 8 group compared to the placebo group. If at month 4, somebody still has significant symptom burden of myasthenia, so if the MG-ADL is still 6 or above, then they will get Descartes 8 open label. So somebody who was randomized to placebo, they will still have the opportunity to receive Descartes 8, and somebody who received Descartes 8, not everybody is a responder, so if somebody does not respond and there are additional cells available, they will receive additional Descartes 8. although we expect that most patients who get these open label infusions will be those who are randomized to placebo. And then there will be continued follow-up all the way to 12 months of treatment, because we really want to see and demonstrate the durability of effect, because going through apheresis and 6 infusions is less of a burden than being on treatment all the time, but it's enough of a burden that you really want to see long-standing effect from that treatment course. These are the key inclusion criteria for the study. So I already mentioned antibody positive myasthenia gravis. What's important is that the antibody doesn't need to be positive at the moment of enrollment. It's enough that there is a documented antibody level within the last 10 years, and it needs to be an actual lab printout, not a doctor's note saying that it is AChR antibody myasthenia, because we know that this is very lab dependent, and we know that somebody who has very low levels of antibody, one day it'll be positive, the other it'll be negative, but it still is genuine AChR antibody positive myasthenia gravis. It needs to be class 2 to 4 myasthenia gravis that was diagnosed at least 12 months prior. So somebody who's had myasthenia gravis for a while, and it's for adults only. MG-ADL score needs to be 6 or above, as I mentioned, and it needs to be severe enough to warrant immunosuppressive drugs. So somebody needs to have had something in addition to acetylcholinesterase inhibitors, Mestinon, to be eligible. And then it's the same background medications allowed as with the phase 2 study. So prednisone of 40 milligrams per day is allowed, provided that the dose was stable for at least 8 weeks. Mycophenolate, methotrexate, and azathioprine are allowed. Complement inhibitors are allowed, provided that the dose was stable for 8 weeks. And if somebody was on FcRn inhibitors, on CD19 or CD20 targeting antibodies, those need to have stopped at least 3 weeks before screening and at least 8 weeks before the first infusion. And if somebody requires frequent IVIG or plasma exchange, there should be none within 4 weeks of the first infusion. But it is allowed to have it during screening and right before apheresis, as long as it's stopped before the first infusion. So what can you expect if you take part? Again, it's apheresis, cell isolation, that's done at our facility in Frederick, Maryland. We grow the cells, we insert the mRNA, the cells are cryopreserved, so it's very flexible in terms of when the infusion can be administered, and it's administered without requiring any chemotherapy in an outpatient setting and with only transient cell modification. So this is the final slide that has information about the study. Many people are familiar with clinicaltrials.gov. This is the identifier, although the way the study is described there can be a bit opaque. We have a more friendly way to describe the study on these 2 websites, at our own website, and there's a study-specific website, and this QR code will lead you to the site. That site also has some general overview of the study and even a pre-screen questionnaire. If anybody's interested, they can check just broadly if they may be eligible or not. So I'd like to thank you for your attention, and I'll be happy to answer any questions.
Thank you so much. We do have a couple of questions. The first one is, how do you make the mRNA patient specific?
So mRNA is not, it's Descartes 8 that's patient specific. mRNA, the CAR construct, is the same for everybody. What's patient specific are the cells. So that's why it requires leukapheresis. Those cells, patient's own cells, are shipped to Frederick, Maryland. We grow them. Well, we select only the killer T cells, then we grow them, insert the mRNA, that's the same for everybody, and then we freeze them. So each lot of Descartes 8, even though it has the same mRNA, is unique to each patient.
Thank you. This next question is, did the patients who reported being symptom-free still have to remain taking other MG medications?
Excellent question. Some did and some did not. So we were fairly strict about allowing tapering of medications on this phase 2 study. We actually said, if you're taking any non-steroidal immunosuppressive, you need to stay on it. No change throughout the course of the study. We didn't want to risk what we call confounding some other effects. But we did say after 6 months, if somebody's on prednisone, you can taper it down. And we saw in the open label study that the average dose of prednisone, the median dose, went from 15 milligrams to 5 milligrams. So most patients were able to get to what we call physiologic dose of prednisone that are not broadly immunosuppressive. It's something that you need because if somebody's been on steroids for a very long time, the adrenal glands that produce steroids, they tend to atrophy. So you can't just stop them. It's actually very dangerous. So those are the physiologic doses.
Thank you. Somebody asked if you could put back up the slide with the site URL.
Yes,
So that
I can
people
do that, and
access that.
I can keep it there.
Thank you. That's great. Thank you.
Of course.
Another question. How long does the intravenous administration take? How much time would the patient stay at the doctor's office as part of the study visit?
Another great question. It's about 2 hours total. So it's pre-medication. I mentioned Tylenol, Benadryl are given to prevent major infusion reactions. Then you wait around 30 minutes. The infusion itself is about 15 to 20 minutes. Let's round it up to 30. That's 1 hour. And then there's 1 hour of observation after infusion just to make sure that there's no major allergic reaction, anaphylaxis, which can always happen because it is a biologic product. It hasn't happened in any of our studies so far, but the risk is always there. So that's 2 hours total in the clinic for the infusion. That's the experience on the day of infusion. Then, as I said, 8 to 12 hours later, there might be some achiness, some fevers. Our investigators in the study told us that most patients, the next day, they just say, hey, I had a fever. I'm feeling better now. Goodbye. Even though we tell everybody to call when the fever happens, sometimes it's late at night, so it doesn't really happen. In only a handful of times did somebody have a very high fever where we said, look, you need to come in. We need to make sure you don't have an infection, that something else isn't happening.
Thank you. This next question is, how does this compare to DNA-mediated treatments?
It's very different. So DNA mediated, those are the conventional CAR Ts. So there you're using a viral vector, so a virus to permanently modify the killer T cell to be permanently a CAR T cell. So it's permanent modification. It inserts itself into the genome. So there is a very, very small, it's tiny risk, but we know it's there, of what we call insertional mutagenesis. So it can insert itself in the wrong place and make the cell malignant. And then because you can't make too many of those, it's a few 100 million conventional CAR T cells that you can make because you've just inserted a virus there. They're not really happy to grow. You rely on them growing inside the body. And to create the right environment inside the body for them to grow, you need to give chemotherapy. That's why those conventional CAR T cells, because they're using viral vectors, require lymphodepletion chemotherapy. And that has side effects of its own. Blood counts go down. There's some immunosuppression from that. They can cause secondary cancers on their own. And then as those conventional CAR T cells grow inside the body, they're permanently modified, so every resulting cell as they divide will be CAR positive. You can't really control the amount. So you tend to overshoot, and that leads to common toxicities of conventional CAR Ts. You may have heard of cytokine release syndrome, neurotoxicity. All of those are the result of this permanent modification and uncontrolled division, uncontrolled proliferation. With mRNA, mRNA is really transient modification. So mRNA goes away after 2-3 days in the body. It doesn't self-replicate. So because the genome is not modified, as the cell divides, those mRNA molecules get diluted out and the CAR protein gets diluted out. So as the cell divides, the CAR number actually goes down. It doesn't go up. That's why the trade-off is that it's 6 infusions, not a single infusion. And it's 6 infusions of a few billion cells, not 100 million cells or 300 million cells. But it doesn't require chemotherapy and you don't overshoot. So there's little to no risk of cytokine release syndrome and neurotoxicity, we think.
Thank you. This next question is, would you accept patients from abroad?
So phase 3 is a global study. So we have centers in the US, in the EU, in the outside of the European Union, in the UK, Serbia, and Turkey. So it is a global study. And on clinicaltrials.gov, there's a list of sites that are currently open and it's being updated, or at least the study locations. And on the study website itself, if you go through it, you can see where it is closest to you.
Thank you. Once on the market, do you see this as having a curative impact on patients with ADL scores less than 6?
So that's it's a tricky word, cure, that we try to avoid. What we are aiming for is a functional cure. So having somebody achieve MG-ADL of 0 to 1, maybe with one course, maybe you saw the 2 patients who needed more than one course, and that can still happen. As long as we can do that with minimal interference in patients' activities, we'll be happy. So the goal here is to, okay, it's 6 weeks. You need to give a day and a half for 6 weeks straight. But after that, you don't have to think about when will I need my next dose. If you're a student and you're away, like what do I find another neurologist somewhere who can prescribe the drug? Do I have to go back home? If you're somebody who spends half the year north of the country, half the year south, like how exactly that works? Do I need 2 sets of medical teams? We hope that this will give at the end people freedom to just have the 6 weeks in a year and then be good for at least a year.
Thank you. If you participate in the trial and have a good result, how long can you repeat this therapy? And what would the timeline be when you might expect FDA approval?
So we haven't, it's years. So we don't know exactly, but it's the nature. We just started this study in May, and we hope to complete it as soon as possible, but that's one rate limiting factor. The second is I couldn't possibly comment on any timelines now. So we hope soon, but it's still a number of years. We're not talking months here. And I'm sorry, what was the other part of the question?
It was how long until FDA approval, and then how many times are you eligible to get the treatment after you complete the 6?
Yes. So on study, it's a single infusion with the option of, or sorry, a single treatment course, 6-week course with an option of 6 additional infusions at 4 months. Part of the study. Now, if somebody has significant symptoms after that, like 3 of our patients did a year after initial treatment, it wouldn't be part of the trial. There is something called expanded access or compassionate use program that we hope to, and we're actually mandated in Europe to use to offer treatment that worked in a trial to offer it outside of the trial. So it would be that mechanism.
Thank you. This next question is, would the patient be eligible if she has a history of a malignant thymoma?
That is, so we allow thymoma. The malignant part is something that our medical monitor would need to review the history in detail and adjudicate to see what the actual pathology report is. And because there are some, I'm an oncologist, so I think I can say this. There are some cancers that aren't really, you can classify them as cancers or not as cancers. And depending on the type of thymoma, there is an array of possibilities of what that malignant adjective might mean. So it's something that our medical monitor would need to review. But I would not say outright no, no way, because we do allow some thymomas. We just need to make sure what type of a thymoma it is.
Thank you. Are funds available to help someone travel to a study site?
Yes, yes. So we do have reimbursement for both travel and lodging for a participant and a companion. Because we know we try to have a mix of academic sites and community sites, but it's still only around 20 sites in the US. So we know that people will have to travel, many people will need to travel far. So we do provide reimbursement.
Thank you. This next question is, where is the physical clinic that a patient would have to be seen?
So those are the study sites in the phase 3 study. I mentioned some of them are university centers, some of them are community neurology clinics. And the end goal is for this to be a treatment that's available like any other biologic treatment. You don't need to go to a tertiary care center, to a university hospital to receive any other myasthenia gravis treatment. So your community neurologist can administer them if they have an outpatient infusion center. And we hope that Descartes 8 will be treatment like that. Because it's outpatient and it doesn't require chemotherapy, and the monitoring after that is minimal.
Thank you. This next question is, how long does it take to grow the T cells, turnaround time from apheresis to infusion?
About 3 weeks. Now, that's standard. There are two factors that might affect that. One is trial specific. When is a particular person who is involved in the trial available to do different parts of the trial? So on a trial, it might take longer, not because of manufacturing and the cell process, but because it's a trial. And I don't know, I think many people here have been participating in clinical trials, and you know that some things just take longer when it's a trial. The other is actually patient specific. So we can do infusion in 3 weeks, but many people say, well, I'd rather have start infusions after this trip, vacation, family event. So it can be longer than that. Because the cells are frozen, we ship them, they're in a freezer in the clinic, they can be used anytime after that.
Thank you. This next question is, have any patients been dosed in the phase 3 study, and how long until we might see phase 3 data?
So yes, they have. As I said, the study started in May. The how soon the data, the sooner we can completely enroll the study, the sooner we'll see the data. That's so how soon, it's a wide span depending on the enrollment. But I have to say we've been very fortunate to have almost all the study sites who participated in phase 2 now participate in the phase 3 and ready, up and running to start quickly. And we have many more sites additionally to help with that.
Thank you. There's been a couple questions in the chat about finding more information for the next phase and how to enroll. So I just wanted to clarify that the information on this slide is where you can go to. If you have a cell phone, you can take out your camera and put it on the little square. It should direct you to a website link that you can click on. Additionally, we've put one of the links within the chat on Zoom, so you could click on that link if you're trying to get to the website as well. We just want to make sure everyone knows how to get where they need to go. Another question is, long-term, if necessary, will a second apheresis be required, or can you simply grow more cells?
It depends. So we are able from a single apheresis to get up to 12 infusions. It depends on a number of things. We're finding out now it depends on the machine that's being used, of all things, that some machines, apheresis machines, can actually give more cells than others. It also depends on background therapies, on age. Younger cells tend to grow more than older cells, but it's at least 6 and up to 12 infusions from a single apheresis. There's nothing preventing a second apheresis. So if needed for a second, third treatment course, you can do a repeat apheresis to produce additional cells.
Thank you. Uh, are patients with multiple autoimmune diseases eligible?
It depends. If it's an autoimmune disease whose treatment is also known to have an effect in myasthenia gravis, then probably not. If it's some autoimmune disease where the treatments are not interacting, it's different, then they would be. There isn't a broad exclusion any autoimmune disease, but it's very specific into what the background medications are. So again, it would be talking to the medical monitor and checking, okay, this is allowed, this is not allowed.
Thank you. This next question is, why were seronegative patients dropped from part 3 of this study?
So we saw very good responses to Descartes 8 in parts 1, 2, and 3, so in phase 1 and phase 2 of the study in seronegative patients. In the phase 2b, we saw high placebo responses as well. And that's something that's known. So in order to have the study complete as soon as possible, we needed to limit it to AChR antibody positive patients only, because otherwise, including others, it would have extended the study both in terms of size and in terms of duration. Now, there are patients who have seronegative myasthenia who have been treated before. There is data that there. There is nothing preventing us from doing a separate study in patients who have seronegative myasthenia gravis once this study is completed. And in the meantime, I would encourage anybody to look at the expanded access, and there is an expanded access policy on our website that if somebody has significant disease with significant either affecting their life significantly and there's no treatments available, we can consider expanded access use as well.
Thank you. This next question, is there any risk that fever and chills causes unblinding? Do you expect that the pre-medication will help reduce fever and chills?
So we do expect the pre-medication to reduce them. That's why we're using them. It is potentially unblinding. However, on the study, we use an independent, what we call an independent rater. So the person who's looking at the scores, MG-ADL, all of the other scores, we don't need to go into the alphabet soup of that. They actually are not involved in any other study activity, and they don't know any side effects that the participant may have had. So it's an independent rater, and that's why we hope to avoid any potential unblinding there.
Thank you. There's a couple questions about will the presentation be available? I just want to remind everybody that yes, it will be. We are recording it and we'll be able to share it online, so you'll be able to view it again. And that is the end of our questions. I want to thank you for the time that you took today, Milos, to go walk us through this. It's very informative and very helpful. And thank you, everyone else, for joining us today.
My pleasure. Thank you.
Thanks. Take care.